I would like to thank the Pediatric Trauma Society for giving me the opportunity to present our work. First and foremost, we have nothing to disclose. Trauma patients are at an elevated risk of developing venous thromboembolism. Children, while at a lower risk than their adult counterparts, are not exempt from suffering devastating complications from venous thromboembolism. Unfortunately, standardized protocols do not exist for pediatric trauma patients, and the management is still based on clinical decision. The Pediatric Trauma Society and the Eastern Association for the Surgery of Trauma recommend DVT prophylaxis in pediatric trauma patients older than age 15. They also recommend using DVT prophylaxis in younger post-pubescent pediatric patients with injury severity scores greater than 25. We recently published our work in the Journal of Pediatric Surgery. We showed that for all pediatric trauma patients between the ages of 10 and 17, receiving heparin as opposed to low molecular weight heparin resulted in lower DVT, PE, and mortality. The next natural question that we wanted to tackle was, how does this relationship stand in severely injured pediatric trauma patients? Thus, the aim of our study was to evaluate the outcomes of severely injured pediatric patients who received low molecular weight heparin in comparison to unfractionated heparin. We hypothesized that severely injured pediatric patients who receive low molecular weight heparin, as opposed to unfractionated heparin, have better outcomes. We performed a 2-year 2015-16 analysis of the pediatric ACS TQIP. We included all pediatric patients younger than age 18 with severe injuries, defined as an injury severity score greater than 25, who received pharmacological thromboprophylaxis. We excluded patients who were declared dead on arrival and those who were transferred. Injury characteristics were defined using abbreviated injury severity scores and injury severity scores. We also utilized ICD-9 diagnosis, ICD-9 external causes of injury, and ICD-9 procedure codes. And here are the statistical tests that we used. Our primary outcomes were DVT, PE, and survival. Secondary outcomes were hospital and ICU length of stay. Moving on to our results, the mean age of the low molecular weight heparin group was 2 years older than those in the unfractionated heparin group. The two groups were similar in terms of demographics, vitals, and injury severity. However, the median GCS was 10 in the low molecular weight group versus 5 in the unfractionated heparin group. The head AIS was lower in the low molecular weight heparin group, but other body region AIS were similar between the two groups. There was no difference between the two groups in the major surgical interventions performed. In terms of outcomes, the low molecular weight heparin group had lower DVT and mortality. Regarding secondary outcomes, there was no difference between the two groups regarding strokes, unplanned return to OR, or unplanned ICU admission. However, the ICU length of stay was higher in the unfractionated heparin group. On multivariate regression analysis, low molecular weight heparin was associated with a decrease in DVT and increase in survival. And here is the visual representation of the Kaplan-Meier survival analysis. To sum up, the use of low molecular weight heparin in severely injured pediatric trauma patients decreases DVT and increases survival. However, the role of low molecular weight heparin in this patient population merits further evaluation. Finally, I would like to thank the Department of Trauma Surgery and my mentor, Dr. Joseph, at the University of Arizona for the support and guidance they provided. Thank you.